to describe about the history of patient's complaint, and a clinical manifestation. The patient is 34 years old gentleman. He works as a mechanic. He is an active smoker and consumes alcohol occasionally. The incident of burn occurred at 1:30 a.m. where he was smoking and threw it into the thinner painting area and explosion occurred. Upon arrival to hospital Lundo, the GCS of the patient is full, which is 15/15. There is no stridor, no singeing of eyebrow, and have a left ocular injury. The CBD is inserted at 3 a.m. and weight is approximately 60 kg. The patient complaint is patient have pain upon moving. He feels chill, have difficulty in chewing food but no problem in swallowing, and he also worried about the changes of his appearance. There are some signs and symptoms we have discovered. There are redness of the skin, edema, and pain based on his facial expression.
Now I will present about normal anatomy of the skin. The skin is made up of 3 layers, which are epidermis, dermis, and subcutaneous tissues. The epidermis consists of 5 layers. The first layer, which is stratum corneum, which contains dead cells with a hard protein envelope. Then it followed by stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale, which is the deepest layer of epidermis and formation site of new epithelial cell by mitosis process. The dermis is consists of 2 layers, which are papillary layer and reticular layer. Dermis layer have elasticity and durability characteristics. The third layer of the skin, subcutaneous tissue, are made up of fat and connective tissues. Next, I proceed to the physiology or the function of each layers of the skin. Epidermis is function to protect our body from bacteria entry and to prevent excessive fluid loss due to evaporation process. Besides, epidermis also play important role in neurosensory and for social interaction. Dermis layer is function as thermoregulation and protect our body from trauma due to its elasticity and durability properties. Last layer of skin, subcutaneous tissue, is function to keep the body's temperature in stable condition and act as a cushion to absorb the pressure and prevent the bone and muscle from damage. Now, I proceed with the pathophysiology of Mr. X. Due to the burn, Mr. X have problem with the skin loss. Mr. X do not have any inhalation problem. Due to skin loss, Mr. X is more prone to suffer from hypovolemia due to excessive fluid loss through higher evaporation rate or through blood loss. Besides, Mr. X also may suffer hypothermia caused by excessive heat loss from body to the surrounding by evaporation process. Since the road of entry widely open due to loss of protective barrier made by the skin, the bacteria or microorganism can easily enter the body, or worstly, it can enter the circulation and cause septicemia to the Mr. X. Lastly, Mr. X also has susceptibility to any types of infection caused by bacteria. I will pass to my friend to present about Mr. X management in the hospital. Thank you.
Next, I will talk about management. Mr. X was sent to Lundu Hospital before he was referred to HGH. Emergency management will take place at Lundu Hospital. As for fluid resuscitation, treatment are given to Mr. X based on the Parkland formula. At the Lundu, they counted the TBSA was 40%, but in HGH was 25%. The TBSA was 25% using lump and bundle. So, based on that, Mr. X was overloaded with fluid as the Parkland formula using the TBSA 40%. CVD was inserted to monitor urine output. As for burn wound, the wound was applied with the silver sulfide diazine cream. Next, management in HGH. Mr. X had a plastic and reconstructive surgery on the 30th March, which is post-burn day 3. The procedure done was tangential excision and split skin graft over the neck, chest, and lower limb. Next is the wound management. Upon the arrival at the SGH, blister was removed at face and gel and oxide were applied. The other side of wounds such as neck, ear, left upper limb, and bilateral lower limb, the rafting done and applied with gel, paragel, and oxide. Post-burn day 2, the loose slough are removed at the wounds and dressing were applied. After the surgery, the face were applied with oxide and the face are red and clean. As for ears and the split skin graft SGG site, Baticrust were applied. Baticrust function for prevent infection in skin loss. At the donor site, which is the bilateral type, Catostat was applied. Catostat is to absorb, exudate, and protect wound from contamination. And as for the other burn wound, uh, Alcoxide Agiburn was applied. Alcoxide Agiburn is for absorb high amount of wound fluid and bacteria and creates a soft cohesive gel that intimately conforms to the wound. It also maintains a moist environment and aids in the removal of non-viable tissue. On the 15th March, liquid paraffin was applied and the other wounds are still on dressing. The wound inspection for Catostat will be on the day 5 and Baticrust on the day 10. Medical management. On the 12th March, Mr. X continued with the Parkland formula and after finish the Parkland formula is continued with IV drip 3 liter per day of normosaline artesunate with dextrose 5%. As day passed by, the amount of IV drip was reduced. Urine output was monitored and Mr. X has good urine output. Mr. X also was propped up to 30 degree and the left upper limb and both lower limb were elevated to ensure good blood supply. Lastly, pharmacology management. This is the list for pharmacology management for Mr. X. Other than that, Mr. X was also on patient control anesthetic morphine, PCAM.
Okay, now I'm going to talk about the physical assessment on Mr. X. The first assessment is about the percentage of total burn surface area of Mr. X. At Lundu Hospital, he sustained second-degree burn at the anterior surface of the face, circumference neck, anterior chest, left upper limb, and bilateral lower limb with total burn surface area of 40%, with left ocular injury, total epithelial loss with haze that obscures iris details. Meanwhile, the percentage of total burn surface area of Mr. X is assessed by using Lund and Brother chart at Sarawak General Hospital, and the result is obtained that he sustained second-degree burn at the anterior surface of the face, circumference neck, anterior chest, left upper limb, and bilateral lower limb with total burn surface area of 25%, with left ocular injury, total epithelial loss with haze that obscures iris details. The depth of the burn is mid-dermal. Next is the review of patient's eye. At Lundu Hospital, he has mild eye pain, redness, tearing, and there are no flashes or flutters, and table below shows the reading of right and left vision as well as the condition of the patient's both eyes. Next is the initial TPR, blood pressure, and SpO2 of Mr. X. For Glasgow Coma Scale and general condition of Mr. X, upon arrival, patient is alert, GCS is full, no difficulty in breathing, no stridor, and patient was experiencing too much pain. For the pain score assessment, Mr. X rate the pain at 3/10 over the face, neck, and also chest area. Meanwhile, he rate the pain at 4/10 over the back of the neck, back of the shoulder, and also back of the right hand area. Mr. X also is on PCM 2 mg per ml. This is the results of blood investigation and chest X-ray of Mr. X. For intake and output chart,
Mr. X's urine output is under normal range, about 800 to 1500 ml per day, and the urine is clear and there are no dysphagia present. This is the result of neurovascular assessment. It is done 4-hourly on Mr. X.
For nursing care plan, we came out with the idea to choose 4 nursing diagnoses based on patient's current condition, in which the time frame was the week that we have been placed at the burn ward, which from 13 to 14 and 16 to 17th of March 2017. And then we chose 4 prioritized nursing diagnoses based on patient's complaints. From the prioritized nursing diagnosis, we chose 2 diagnoses and we came out with 6 nursing interventions with their rationales for each of the diagnoses. We prioritized the nursing diagnosis based on Maslow's hierarchy of needs, which clearly demonstrated the human needs in daily living. The first nursing diagnosis that we chose is impaired skin integrity, related to disruption of skin surface with the destruction of skin layers as evidenced by the absence of viable tissue. The interventions that we chose are basically to promote wound healing process and also improve patient's skin condition. The second one is risk for infection secondary to loss of skin barrier. The interventions for this nursing problem are focused on the prevention of infection to the patient's wound.
불타오르네.